Thank you, Professor Kato. Long time no see you.
Yes.
So we start the first speaker is Professor Yoshimura from Wakayama, Japan. The first speaker, and the second
Yep.
speaker next is Dr. Stefan from Indonesia. Professor Yoshimura from Wakayama talk about carotid artery stenting and intracranial arterial percutaneous transluminal angioplasty. Please, Dr. Yoshimura, takes time for 15 minutes.
Okay, thank you. So can you see a slide?
Okay, fine.
Okay.
Okay. So I'd like to talk about the cardiac stenting and intracranial PDA. This is my overview. The first topic is surgical strategy for cervical IC stenosis. IC means, internal cardiac arteries. So we have two options of surgical strategy for cervical IC stenosis. One is, cardiac endarterectomy, and the other is cardiac stenting. My main topic is here, cardiac stenting, we call CAS. Notably, in Japan, neurosurgeons generally manage cervical lesions because cervical IC stenosis is a neuro disease and it's a big problem for atherosclerotic thrombosis. So, surgical procedure of CAS has 5 steps. That's very simple. The first steps we call embolic protection device (EPD) deployment. The second step is a PDA, a percutaneous transluminal angioplasty. The third step is deploy the stent, and if necessary, post PDA should be done. And finally, EPD captured and retrieved. That's 5 steps. It's very simple. So we have 2 types of carotid artery stents. One is open cell stents. The advantage is a small metal coverage area, and it has well fitting for elongated winding vessels. But the disadvantage is plug protrusion for the soft plugs. The second type of stents we call closed cell stents. It has large metal coverage area. It enables to hold down the soft plugs and cover and push out, but may cause a kinking for elongated lesion because the stent is a little bit stiff. So, what is the indication of CAS? So we have a lot of clinical evidence for CA versus CAS, but in all evidence, CAS has no superior clinical evidence compared with CA. So CA is still gold standard. So I introduced the 2 famous clinical trials, SPY and CREST. SPY trial is a randomized controlled trial of CAS versus CA for CEA high-risk patients. The indication is over 50% stenosis for symptomatic or over 80% for asymptomatic lesions. So it has been done with selected devices and selected operators. The result is CAS has achieved non-inferior efficacy and safety compared with CA. The second trial, famous trial, is CREST trial. It is a random controlled trials of CAS versus CA for CA normal and high-risk patients. The indication is over 50% stenosis for symptomatic or over 60% stenosis for asymptomatic. CAS has been done with selected devices and strictly selected operators. And the result is that, CAS has achieved equivalent efficacy and safety. So The third topic is pre-operative evaluations. So we have to do a lot of investigations before the surgery, just CA or the medications. The first point is functional evaluation, symptomatic or asymptomatic. The second point is anatomical evaluations with ultrasonography or CT angiography or DSA. How many percent stenosis the patient have, or how is the access route, or elongated lesions or straight lesions, and so on. Plaque imaging is also important, and it enables with ultrasonography or CT or MRI. The population status is also important. We can see with SPECT or CT perfusion. And for general anesthesia, it is also important for systemic survey. For example, coronary artery disease or aortic valve stenosis or COPD. And we have to choose CA or CAS. We have to choose a type of EPDs. We have to choose a type of stents. So this is a representative case of a soft plaque with black blood imaging of MRI. It enables detecting a vulnerable plaque preoperative. It's a little bit dangerous for open cell stents. This is a very typical case of misery perfusion status for revealing with SPECT. That it is a high-risk patients for hyperperfusion syndrome post-operatively, so we can detect and predict the high-risk patients for hyperperfusion syndrome. So intraoperatively, we can see the hemodynamic changes in real time with transcranial Doppler or near-infrared spectroscopy. It's a very important monitoring during CAS. So I will introduce embolic protection devices, EPD. We have two kinds of EPD. One is distal protection devices, and the other is proximal protection devices. Distal embolic protection devices is like a filter type. The advantage is patent blood flow during CAS because the filter is passing through the blood only catches the debris like this. You can imagine a coffee filter. But disadvantage is not captured of all embolic debris, like oily or liquid debris might be passing through to the brain. The other distal protection device is a balloon type. It is available in Japan, what we call optimal wire. This is a wire with balloon. So we can inflate the balloon, distal part of the lesions, and rest of the flow and do the PTA or stents. And after, spray the debris with blood and deflate the balloon. So only clean blood is passing through to the brain, like a breather. So the second protection device, the proximal embolic protection devices, it is a little bit complicated systems. We have a Wilson collaterals from left side or right side or right side to left side. So if we occlude common carotid artery and external carotid artery and open the catheter tip from the extra body, so through the Wilson collaterals and the flow is reversed from the brain to the heart. So the debris is retrieved to the outside of the body. So this is a proximal protection devices. We can do both proximal and distal EPD. We can do the both. This is a devices of a proximal protection device we call MoMA Ultra. This balloon is for the external carotid artery, and the second balloon here is for the common carotid artery. So we can say one case of the carotid artery stenting. The first three, we introduce the wire to the occipital artery and exchange to the MoMA Ultra for the guiding catheter with proximal protection devices. This is a MoMA Ultra. And adjust the position. Okay, keep going.
You can start this from the beginning, please.
From beginning, okay.
Okay.
Okay. So firstly, we introduce a guide wire to occipital artery and MoMA Ultra proximal protection devices introduced here. And adjust the position of balloon here. Inflate the balloon at the external carotid artery. And inflate the balloon of common carotid artery. The underflow reversal, distal protection device. This is a filter type protection devices here. And check the angio. And PTA, pre-PTA has done. Oh, PTA has done. And here's a stent. This is a gold cell type stent. Yeah, stent has been deployed. And post PTA here. Anti-charger. You can see it's nicely opening. That's it. So quickly review their intracranial lesions. So indications of intracranial lesion and PTA and stenting is very restricted indications. So we can do only for symptomatic cases and over 70% stenosis and refractive for best medical treatment. So the three conditions are mandatory for me. This is a famous random control trial samples. It is a control trial of PTA and stenting versus aggressive best medical treatment. Surprisingly, no significant difference on PTA or stenting for symptomatic intracranial region-based stenosis. So it is because it is a reason for the strict indications of PTA
2 minutes
stenting.
left.
Okay. So last topic is challenge. We have to just quickly challenge cases. This is a challenge case, the chronic total occlusion CTO. You know this is a gold standard for the CTO lesions. It's ECIC bypass surgery. Yeah, it's not neurovascular lesions, but strictly selected cases. We can see the contralateral ophthalmic artery here, and the lesion is really proximal. This is a C5 and upper cervical lesion. So we can do the antegrade flow with PTA and stents, but it's very dangerous manipulation. So these are challenging cases, but we can do for the limited patients. So the conclusion is it's available to there are two kinds of stents, the open cell and closed cell stents. We can use two kinds of EPDs, proximal and distal EPDs. And anatomical and plug imaging will have the best choice EPD.
Thank you. Thank you.
Please.
So we
It's done.
continues for the second speaker
That's a final slide.
is Dr. Stephen from Indonesia. Talk about intracranial atherosclerotic disease, issue and controversies. 50 minutes time.
Yeah. Thank you, Professor Japardi. Thank you, Professor Kato, Professor Kuwayama, and also Professor Yoshimura. Let me share my PowerPoint. Sorry, can you see the?
Yes, please go
Okay.
ahead.
Yes.
Thank you. So I don't have any conflict of interest. This is our neuroscience team in Medan. We have neurologists, neurosurgeon, also radiology intervention. Okay. I'm also part of Kuwayama team. Always learn a lot from Kuwayama sensei and the others members. And then I'm come from Medan, the west part of Indonesia. This is my hospital, Silom Hospital di Garsuya. Okay, so we know that ICAT is a progressive pathology process characteristic by atherosclerosis plaque formation affecting the major intracranial artery agonistic of the disease. ICAT usually cause at least 10% of ischemic stroke in the worldwide, and 50% cause for the Asian ethnic. So this is very common disease in Asia. We know that ICAT can cause in situ thrombosis or occlusion, and also can cause artery-to-artery embolism. And also the luminous stenosis can cause hemodynamic compromise and also hypoperfusion. And if is affected in the branch, can cause a branch occlusive disease that cause a lacunar stroke. There is a lot of imaging modality to diagnose the ICAT, but the gold standard is DSA, and in my hospital, I can only do DSA, CT, and also MRI. We know that the first trial for the ICAT is WASIT trial. From it compare aspirin and warfarin, and from the result we know that aspirin is superior than warfarin, but for the recurrent stroke rate there is no difference between the two arms. So this research indicate that antiplatelet is more superior and often used for the ICAT for the prevention. And after the WASIT trial, we focus for the other optimal treatment. So we particularly exploring the angioplasty with stenting. And in 2011, the SAMPRIS trial was conducted to compare PTS with medical treatment compared to medical treatment alone. The result is very surprising. The trial was stopped earlier because PTS group have a very bad result. So patient in a medical arm, so patient in the PTS and medical treatment have more stroke and death compared to the medical treatment alone. And then they compare the SAMPRIS to the WASIT for the at least 30 day and 1 year's stroke and death. So the primary thought was found that dual antiplatelet therapy, increased statin use, more consistent of antihypertensive medication, and certain lifestyle modification based of these two trials. And the subgroup of the SAMPRIS that PTS with medical treatment do not have a great benefit for the ICAT. The other trial is a visit trial. They try to evaluate using a balloon expandable stent with medical treatment. This trial also stopped earlier because the result is also bad compared to the medical group. For the 30-day primary safety endpoint, for the intracranial hemorrhage, for the 1-year primary outcome, all was inferior to the medical group. So this finding do not support the use of balloon expandable stent for the symptomatic intracranial arterial stenosis. The latest trial for the PTS is a WIF trial and WOFEN trial. The WIF trial, wingspan stent system post-market surveillance. This result also stopped earlier, but not because of the bad result, but they are surprising because the result is good. So this result, the conclusion is with experienced intervention analysis and proper patient selection, the wingspan can be used and demonstrate a low periprocedural complication rate and also have an excellent safety profile, 2.6% for the periprocedural stroke, bleed and death rate. And then they continue the study. They access the 1-year follow-up from the WIF trial, they call WOFEN trial. And then from the 129 patients who were already standard, it demonstrated a relative low 1-year stroke and death rate, only 8.5%. So this new trial have a very different result from the previous trial. But some intervention, they develop new technique. They call submaximal angioplasty, because since the sample deficit have a bad result, so they argue that submaximal angioplasty may have a less periprocedural stroke risk and safer than stenting. So what is this? What is submaximal angioplasty? It's a marginal increasing diameter of affected blood vessel, and the blood flow markedly increase involve a balloon angioplasty without dilatation to the normal side. So this is based on the formula, Bartholomew's formula. So if we increase 10% of the diameter, then it will be increased 46% of the blood flow. And if we can increase 20% of the diameter, 200% of blood flow will be increased. So this is the difference. In the middle, we have this is primary angioplasty. We try to make it normal. And then the third one, this is submaximal angioplasty. So we only use undersized balloon inflation. So this is one of the systematic review and meta-analysis. They used 19 studies for the incidence of 30 days, mortality 30 days, and also incidence stroke on or death at 30 days. It's very low compared to the medication. So this submaximal angioplasty might be a promising alternative treatment in the treatment for the symptomatic ICAT because of the favorable technical profile, periprocedural safety, and also long-term efficacy. Another meta-analysis from 9 studies also showed that 30 days and beyond 30 days stroke and death also lower than medication. So and there are also no significant difference between the anterior and posterior circulation. So they conclude that submaximal angioplasty represents a potential promising intervention for the symptomatic ICAT. But the latest guideline from the European Stroke Organization, they published the first thing that highlight is low evidence based on recommendation for the antiplatelet as the antithrombotic double antiplatelet as an antithrombotic treatment of choice for symptomatic patient. And then moderate level evidence was found to recommend against the use of oral anticoagulant. So we prefer to use antiplatelet than anticoagulant. And then endovascular therapy for the intracranial with intracranial angioplasty or stenting is not recommended as the treatment of first choice in a high-grade symptomatic ICAT. This is a moderate level evidence. So the result is very the new guideline is very surprising. So in this moment, I like to share several of my cases. So I have 63 years old patient with the recurrent cerebral stroke in a month, although being given for the aggressive medical treatment. So we do the DSA. The DSA show that a severe stenosis is around 19% stenosis with the patient already have a recurrent symptom of cerebral stroke. So we do the submaximal angioplasty. We dilated the balloon for achieve 80% of the total lumen, and the result is quite happy. We are happy with the result. Previously, the flow on cannot achieve until the top of the basilar, and after the angioplasty, the flow already can go to the top basilar, go to the P1, P2, and whole cerebellum. The patient until now is already 2 months. The patient do not have any symptom of stroke anymore, and still continue aggressive medicamentosa. And then this is another cases, 55 years old patient with expressive aphasia and recurrent weakness on the right side from 2 months ago, already have aggressive medical treatment. So from the DSA, we found that there is severe M1 stenosis, and then we do the submaximal angioplasty, and the patient now already can activity like usual. There is no recurrent stroke anymore. How about stenting and angioplasty for the small cerebral artery? So this is one paper from Jaidat. They have 10 patients with ICAT and refractory medical therapy. The treatment is primarily balloon angioplasty and angioplasty with stenting. The mean treatment is 80% stenosis with post-treatment only 20%. No major peri-procedural complication, including hemorrhage and mortality. The follow-up 18 months, only one symptomatic restenosis would have to retreat and successfully retreated. All patients had good function outcome with Rankin scale, modified Rankin scale 0, 80%, and 1 for 2% on the follow-up. So I also have one patient with the small vessel with the small caliber ICAT, 58 years old with recurrent stroke, although have aggressive medical treatment. So we found that this is a stenosis. Then we do the submaximal angioplasty. We successfully recanalize about 80%, and the patient do not have any recurrent stroke anymore. So it's already 6 months from the treatment. And how about for the LVO, large vessel occlusion with tandem ICAT? We know that mechanical thrombectomy is a must, but should we do the angioplasty directly, or should we just left the ICAT for the best medicamentosa? So this is the research. This is trial 475 cases. They put into 3 groups: early angioplasty and stenting, and then next is non-angioplasty and or stenting, and then the last one is late intraprocedural angioplasty or stenting. So between that 3 group, early angioplasty and or stenting group have a better outcome compared to the others. So the conclusion is angioplasty and stenting should be performed at early stage for the ICAT related with the large vessel occlusion. So this is also one of my cases. 58 years old male come with unconsciousness. After the thrombolysis, we directly do the DSA. There is still a total occlusion in the M1. Then we do the mechanical thrombectomy using the stent retriever. The flow is coming, but we can see there is a severe stenosis. So we do the angioplasty using the gateway balloon. We achieve around 80 to 90% the canalization. So and then after 2 months, the patient regain modified Rankin scale of 0. So all the deficit neurologists already recover well. And for the conclusion, medical treatment is still the first choice for most cases of the ICAT, whether asymptomatic or symptomatic. The rationale for current ICAT angioplasty criteria for patients that fail medical treatment and hemodynamic comprise occur with severe stenosis and comprise collateral, and for rescue therapy in large vessel occlusion with thrombectomy. Improvement in endovascular technology have also made angioplasty and stenting for ICAT much more straightforward and also safer than the Semprez trial era. I want to like to acknowledge this all the people that very have made me to can be like now. Thank you very much.
Okay, thank you, Dr. Stefan. So we continue for next sessions is discussion. First, please, Professor Kuwayama from Japan for discussion.
Okay. So thank you very much for a nice talk, Professor Yoshimura and Stephen. And first of all, I have some questions to Professor Yoshimura. Can you hear me?
Yes.
Okay. Okay. So thank you very much for your nice talk
Thank you.
about carotid artery stenting and overview. And I have several questions. The first question is, which is the ideal protection system for the patients of a symptomatic patient with unstable plaque? Unstable plaque.
Thank you for the questions. Unstable plaque is dangerous for the cardiac artery stenting. So we usually do the first proximal protection and flow reversal. And after that, distal protection is delivered to the distal part of the lesions and opening balloon or filter devices. So we do the proximal and distal, the double protection.
Double balloon, you mean?
And I mean the flow reversal, the two balloons for common cardiac.
Okay.
Yeah.
Mhm.
Common and extracardiac. Yes.
Okay, so
And we choose the closed cell stents for soft plaque. Yeah.
you mean a wall or a Casper, right?
Yes.
It's
Yes. Right.
kind of a braided stents, right?
Yes. Yes.
Okay. Okay. So the second question is, how do you protect? How do you detect the hyperperfusion syndrome or hyperperfusion phenomenon, and how do you prevent the patient from having intracranial hemorrhage caused by hyperperfusion syndrome? Because hyperperfusion syndrome is a very, very rare phenomenon, but if it occurs, it's very, very severe. Maybe the occurrence rate will be 1 to 2% of the patient after treatment of a carotid endarterectomy or carotid artery stenting. But if it occurs, it will be devastating state. So we must know how can we protect and how can we detect from the hyperperfusion.
Okay. Much. This is a very important to predict the hyperperfusion high-risk patients. The first, pre-operatively, we always do the SPECT investigation, and we estimate our stage 2 patients, misery perfusion patients. It is a high risk for hyperperfusion syndrome. And if we meet the patient during the surgery, during the case, we always monitoring with NILS, near-infrared spectroscopy, and measuring the blood flow on the ipsilateral side and contralateral side. And just after the surgery, the ipsilateral side of blood flow is increasing about 1.5 to twice over. It's a high risk for hyperperfusion. So after surgery, the patient is going to the ICU and lowering the blood flow to about 90 millimeter mercury. So we are very strictly keeping low blood pressure for 3 to 7 days, and always monitoring with NILS or transcranial Doppler. And that's important to measure the cerebral blood flow.
Okay, so how do you know the how do you how do you know if the whether the patient will have hyperperfusion syndrome after treatment or not? Can you know by a CT or MRI or DSA or some CBF study?
Yeah. Thank you. We have a lot of modalities for measuring the CBF study, but for me, I always do the monitoring with NILS for real time, and the next day we already do the MRI for the embolic complication or some other situations. But additionally, we also do the ASL perfusion study. So we can detect the perfusion changes on MRI with any other injections or drugs. So we do the ASL perfusion, and we always do SPECT if necessary a few days after, and we always do the NILS, near-infrared spectroscopy. So we do the 3 modalities to detect the hyperperfusion phenomenon. Yeah.
Thank you very much.
Thank you.
So do I have more time? Is it okay to
Yes.
have some question to Stephen?
Yes.
Okay, thank you. So Stephen, thank you very much for your nice literature review and overview for the ICAD, intracranial arterial disease. Thank you very much.
Thank you, Sensei.
Okay, so I have some questions. Which vessel will be good for PTAS, PTM stenting? Which part of the vessel? I mean, M1 or basilar artery or IC petrous region or vertebral artery V3, V4, or much distal artery, like you told us in this slides. You did PTA for M2 stenosis, right?
Yes, Sensei.
What part of the vessel is very safe and effective, very responsible for PTA treatment?
Okay, thank you, Prof. So I only will do PTA or PTS if the patient have a asymptomatic refractory stroke. So after two times of stroke, then we will do the DSA to evaluate the vascular. If there is a compromise of the flow to the distal, and then is there any compromise to the distal, then I will do the angioplasty, Prof, using the balloon. So I will first I will use submaximal angioplasty technique. If it's success to open the flow, I will stop. So I still not well, I mean I'm still not familiar to using stenting like wingspan or the others, Prof, because from the most literature it state that stenting is still is still dangerous, still have a more a pre-procedural complication compared to the only do the balloon. And I avoid doing the balloon for the lacuna infarct, like occlusion in the small branch, Prof. So because it will not help. Well, I mean it will not help to the blood flow. Although we do the stent, or although we do the angioplasty. So mostly I will choose a large vessel and the place without any branch arterial, Prof.
Okay, thank you very much. In my experiences, I think the MCA M1 stenosis and the trunk of basilar artery stenosis is very, very dangerous. If we do PTA or stenting for these vessels, we will have some trouble in the perforating artery. So usually we do PTA and stenting for petrous ICS stenosis and vertebral B4, V4 stenosis. These two vessels are very, very safe and very responsible to the treatment. This is my experience. Thank you very much.
I'm so sorry if I made mistake.
Okay, it's no problem. Okay, thank you very much.
Thank you, Professor. So the next is discussion by Dr. Michael from Indonesia. Please.
Hi, thank you so much, Professor Iskandar, Professor Yuko Kato, Professor Yo, and Professor Kuwayama. So thank you. I would like to asking a very basic question to guide to more critical thinking about the PTA. My question to Professor Yoshimura is, does the PTA alone has a rule, or is it only for bridging to stenting? Because we know that, of course, PTA have higher recoil or restenosis, but I would like to know about your opinion. Just PTA is on have a role only the bridge to stent or what? Thank you.
Oh, can I answer? Or Dr. Steve?
Okay,
Can I
please,
answer first?
Professor.
Okay. Okay. In my opinion, for intracranial lesions, the best choice is the best medical treatment. Then the second choice is only PTA, because the Dr. Stevens show a lot of evidences for stenting or PTA only. So the stenting is not so excellent data for clinical trials. So, but if some dissections or some trouble causes, it is no choice to put the stent for the recovering the recanalization. So only emergent cases we put the stent, but the best choice for interventions is a PTA only. It's in my opinion. So, how's Dr. Stephen?
Thank you, Professor Yoshimura. I've also sent out with Professor Yoshimura. But angioplasty is still the first choice. if when we do the angioplasty, if there is some dissection or something trouble happen, we have to put stent. We have to put stenting, or if after we do angioplasty and we still do the follow up, if the patient get restenosis again, so that's also I will put stenting for that cases. So angioplasty with balloon only. I only will do one time, and for the second time restenosis, I will put stent in that cases. Thank you, Prof.
Can
Thank
I
you so much.
go?
So,
Michael?
yes, Professor, how's it going? How are you? Long
Yeah,
time no see you. Sorry.
the circumstances are much different. If
Yep.
you talk about the PTA for the intracranial artery, stenting is
Yep.
very dangerous. But if you talk about for the carotid neck cervical carotid artery, we should do stenting because we will
Yep.
have recoiling or restenosis or dissection phenomenon after PTA only. And carotid artery stenting is very, very safe and very, very effective treatment. So we should do stenting for carotid artery. But intracranial artery, the situation is much different. It's a very dangerous procedure. It's my
Thank you,
opinion.
Prof. Yes. Thank you. Because I want to give a little question, so I hope the discussion become developed more interesting. So, but based on this topic, so I want to add more. There is like your experience in the drug-coated balloon for future PTA, because you know, right? Everyone's put the stand because of they want to prevent the restenosis or recoiling. So some of papers now introduce about drug coating balloon have more superior to the traditional one. And the second question is about in ICAT, is the suboptimal, submaximal angioplasty is safer than aggressive PTA in ICAT? So maybe Dr. Stephen can help me. Thank you.
Thank you very much. Suboptimal dilatation is a very, very important technique. And I think it's very safe technique. I agree with you. Thank you. Okay.
Thank you, Prof.
Any discussion? No more?
Yes.
Okay.
Thank you, Prof. Maybe I have a small thing
Please, to seven.
Thank you, Prof. So now, yes, like Dr. Michael stated that now they are developed much more developed for using drug-eluted balloon, and they want to how to say it, to prevent to more effective of the prevention of the recoil and the other things, but still the clinical trial is still not still not supported for the primary use of the drug-eluted balloon. So still depend on the, I think it depend on the situation of the cases, and also depend on the surgeon, which one in which situation they would like to use on balloon only or balloon with drug-eluted. Maybe Professor Kuwayama can give some advice. Thank you, Prof.
Okay. So do you want me to talk something? Huh?
Yes.
You talk about the risk factor for the vessel PTA or stenting, Stephen.
Using a drug-eluted, Prof. Now drug-eluted balloon is
Drug-eluting.
yes, Prof.
It's in the field of coronary stenting. We have no drug-eluting stent for intracranial artery, and I don't think we need it for the intracranial vessel, because we have very, very less patient with the recurrent stenosis after PTA or stenting. especially in the carotid artery. But intracranial artery, I don't know much. Okay.
So Professor, and maybe I'm asking more one question about regarding the hyperperfusion topic. I'm asking about the optimal timing for PTA and etc. in acute stroke via early rescue or delay elective because of maybe we facing of patient with recurrent stroke. So do you have any comment about do this in recurrent stroke patient? Thank you.
So to whom do you ask? To me or to Professor Yoshimura?
Or Professor Yoshimura and Dr. Stephen, and also if Professor Kuwayama can ask more, so of course I'm very
Okay.
honored to hear it. Thank you.
Okay, Yoshimura, please speak first.
So you mean the do you mean the stage of hyperperfusion syndrome? Do you ask me?
Yes, regarding the hemorrhagic transformation is high in recurrent stroke. So do you have any like your experience in optimal timing for PTA after stroke, acute stroke,
Okay,
rescue or
timing,
delay or something?
Okay, generally the hyperperfusion syndrome occurs earlier than CEA. So for the cultural understanding, hyperperfusion syndrome may occur the day 0 or day 1. So you know that, but the symptom is very variable. Just only the headache or seizure, or the massive hemorrhage, or only a very thin subarachnoid hemorrhage. It's variable. It's variable the symptom and abnormal imaging. So the mortality is a little bit high, but the morbidity is very high. So multiple one case is down 1.1 or 2 lowering molecular ranking scale. So it's a very dangerous complication.
Thank you, Professor.
Thank you, Dr. Michael. I think for ICAT, hyperperfusion syndrome is very rare, but after doing the angioplasty or doing the stenting, I think it's a must to control the blood pressure. So we have to put the blood pressure in a normal state. So that will decrease the chance of the hyperperfusion syndrome in a very low chance. And then after the if I'm not mistaken, Dr. Michael asking after the thrombectomy we do the angioplasty, right?
Yeah, okay, it's based on the case, but let me hear about yours.
So based from the clinical trial that I showed Dr. Michael just now, they compare 3 groups. So early angioplasty after thrombectomy and then non-angioplasty after thrombectomy. So the superior one is early. And for the recurrent stroke, also for the bleeding, it's very low for the early angioplasty after thrombectomy. So it suggests to do after thrombectomy. If we found there is ICAT, we directly do the angioplasty. Thank you, Dr. Michael.
Thank you so much. Thank you. Thank you, Professor.
Thank you for all of your attention, I think. So today our webinar has ended. I will hand this webinar to Professor Kato. Please.
Okay, thank you so much, the Iskander, and also the 2 speakers, and also the discussant of that, Dr. Kuwayama Sensei and Dr. Michael. So we learned a lot because I'm not the endovascular surgeon, but I enjoyed all talk. I think recently I experienced the peripheral ACA A2, A3 part is very severe stenosis. So at the beginning, we made a plan to bypass the A3 bypass, but finally we just PTA, no, PTA and put the stents. The patient was very good afterwards, I think. And also sometimes I heard about the restenosis after PTA. So how we can avoid it. So is there some standard line, or you have some knowledge? Please let me know, please. 誰でしょうか。小山先生ですか？
You talk about the restenosis after PTA?
Yes.
For me, I will do PTA again. And stenting is a very difficult situation. PTA will be much safer than stenting. So I will choose PTA once more for the intracranial artery. But if it's a carotid artery, I will do double stenting. Stenting again. Stent and stent in stent. It's very safe way. So the situation is much different between carotid artery stenosis and the intracranial arterial stenosis. Very safe treatment and a very difficult treatment.
Thanks so much. For the most of the case, intracranial, the stenosis is caused by the sclerotic change, atherosclerotic change. So it's quite difficult to dilate of such a small place, I think. So that's my doubt.
Yeah,
thank you very much.
Agree. So the bypass surgery is very effective treatment for that situation.
Thanks so much. Maybe Dr. Liu, you want to ask something?
Yes. For one question to anyone. In almost complete occlusion, in chronic occlusion cases, in what situation that would you decided not to proceed? Is it when you fail to insert the guide wire, or do you always have a backup for surgical team, or doing it in angiosuit in a chronic stenosis, say probably M1 stenosis? Is there any guideline to tell what should be done in chronic stenosis, almost occluded cases? Any speaker? Professor Stephen, probably.
Thank you, Professor Liu. Actually, there is several difference of several paper. So for European Stroke Society, they do not agree to do anything for ICAT. They stand for only use aggressive medication for all cases of the ICAT. But in my opinion, if the almost close stenosis, very severe stenosis that already caused several times of stroke, I prefer maximal angioplasty. I don't need to open until 100% or something like that, but at least I can open at 40 to 50% from 19. I can reduce until 14. I can increase more than 200% of the blood flows according to the Bartholomew's formula. So in that cases, I will do angioplasty, and if fail, we can consider for the surgery either for a bypass or either we do EDAS. I read new trial. They compare bypass and bypass alone and EDAS alone. They said in that paper, it stated that EDAS alone also quite effective for chronic stenosis. Thank you very much.
Thank you, Professor Stephen. Thank you. That's all the question from me. Thank you, Professor.
Liu, can I talk?
Yes, Professor.
You may talk about the chronic.
先生終わった？よかったね。でも、ちょっとえらい時間かかったかなと思ったんだけど、なんか、視点とかなんかのところで。ごめんなさい。
Yes, Professor.
Please continue, Professor.
Kuwayama still mute.
Yeah, muted, Professor.
Sorry. Liu.
Yes.
You may talk about the chronic total occlusion.
Yeah.
Right? And if
Yeah.
it's MCA or basilar artery, it's very dangerous. Although there are some case report, we should not do that. But if it's a carotid artery and if it's in the subacute phase, so 1 week or 2 weeks after total occlusion, we can do recanalization by means of catheter, not the bypass surgery. But it have no clinical evidence. No evidence. So the standard and the very effective way is to have bypass surgery. But we can do chronic total occlusion recanalization sometimes in the very, very good situations.
Thank you, Professor.
Thank you very much.
Is there any question? So I think thank you very much for the all speaker, and all discussion. It's nice discussion. So I think I give back this webinar to Professor Kato.
Okay, so once again, thank you so much. So it was really, I think, good, the webinar. We learned a lot from both speakers and also the discussion. So I think from the very beginning, very basic things we should learn. Maybe I think it's good for especially the young doctors. Thank you so much for your leadership, Iskander.
Thank you, Professor. Thank you.
Thank you.
Professor.
Thank you, Prof.
Thank you, Prof.